Okay, I'll start now. Okay, okay. All right. Good evening. Good evening. Good afternoon, and good morning wherever you are. Okay? So I'll be discussing tonight. Well, it's nighttime here. We're in the Philippines. About oral plastic surgery for the general dentist. Okay. So these are all case-based discussions that myself and my colleagues, my students have done, okay, in the past. So I want to show you some of them. Okay. So here in this discussion, we'll be discussing the defining what perioplastic surgery is. Okay. So these are our objectives. So procedures done in perioplastic surgery. What can you? These are the procedures that you can incorporate in your practices, okay, as general dentists. So I'm not a specialist. I'm a general dentist, but yeah, interested in surgery. Okay? So probably later, among all those the several procedures that I will be sharing, I hope that at least one you can incorporate in your practices. So we'll be discussing about melanin depigmentation. You may be familiar with amalgam tattoos. So it's the same. I mean, it's different, but the procedure to remove it or to manage it is the same. We will also be discussing about connective tissue grafting, a little about it. Periodontists, they do this, but it doesn't mean that us general practitioners cannot do this. We actually can. It's just a matter of practicing it. Okay? Of course, the kind of highlight of the discussion is lip repositioning. This is addressing your gummy smile and aesthetic crown lengthening. Okay? So, okay, so I'm Dr. Carlo Santos. I have a private practice here in Makati, the Central Business District of the Philippines. Okay? I'm a general dentist, well, very much interested in surgery. Um, I have a workshop, a small school that teaches actually general dentists innovative procedures like, yeah, as said, perioplastic surgery, oral plastic surgery, and yeah, your normal oral surgery. I taught in the undergrad in Anciano College of Dentistry. I am the past president of Makati chapter of the Philippine Dental Association and active member of the PCOI or Philippine Society of Periodontology and College of Oral Implantologists, and active member of the Philippine Dental Association. So a little about what we do. So our group, our study group, it's called Center for Innovative Dental Studies. We actually it's a study group where everyone can share their thoughts, their experiences, and about anything about oral surgery, periodontal implants, so anything. So here's some of the posters or workshops that we held. This is yeah, us performing and brainstorming on what we're gonna do. Okay, this is the class that we hold every month. It's a 3-day workshop. Yeah, this is the outreach programs that the workshop does. Okay? So we help, we aid children in their oral health. Okay, let's go to the topic at hand. Okay, so first let's define plastic surgery. So it's a specialty, no, involving restoration, reconstruction, and alteration of the human body. So of course, when we talk about oral plastic surgery, all of those restoration, reconstruction, and alteration of inside the oral cavity. Okay, so I guess you're a little confused. Why there's oral plastic and there's periodontal plastic surgery. So I actually coined oral plastic surgery for the following reasons. Okay, so anyway, before doing your surgery, of course, I suggest that I strongly suggest that correct instrumentation should be used. When I say correct, uh, the principle in flap design, in suturing should be followed. So with proper instrumentation, everything will fall into place. So of course, I'd like to thank Woodpecker, for inviting me here to talk and discuss about our topic for tonight. Okay, so this actually this piezo machine actually is very, you can use this and it will make your life very relaxed when doing your oral surgery, may it be periodontal surgery or oral plastic surgery. Okay, so I want you to meet these three people. No? These three are our past patients. Okay, so this is patient number one. No, I won't disclose the names. Patient number two and three. So you look at them. Patient number one, it seems that she has no dental problem. Okay. Patient number two, actually, well, you can see that a lot of gums, gums are shown, and aesthetically, she's concerned with this. And patient number three, yeah, the same problem with number two. Only two is worse. So they all came to the workshop that we hold, and we actually do the surgery, the oral plastic surgery for free. Okay, so in this lecture you will actually in a way follow the journey in which what we did, their oral surgery journey. Okay? So okay, again, patient number four. So okay, so you'll also see what's done to her. So notice that her gums are dark, okay? And she has a slightly gummy smile. Okay. So the goal of any treatment, the goal of any treatment in this type of procedures, is to enhance the natural beauty in the safest possible manner, which is often multidisciplinary. In the aesthetic world, in the cosmetic surgery world, as general dentists, I think we play a big part in achieving beauty, achieving a beautiful face. Okay, so basically, this type of surgery is your surgery before aesthetic dentistry. Before you put your veneers, as general dentists, we do this veneers, bridges, and we fix the color, the shape, the sizes. So these procedures are the surgery before the aesthetic part of dentistry. Okay, so cosmetic therapy as a dental demand. Okay, okay, so it's actually called, because when you say periodontium, we are dealing with three structures. Periodontium, three structures must be present: the tooth, the gum, and the bone. Okay, you remove one of those, you won't call it periodontium, but that's why it's called perioplastic surgery, because it involves the periodontium. Now, why was the title oral plastic? Okay, I'll tell you. So as you can see in the two pictures, this beautiful girl, So without having beautiful teeth, it lacks, her beauty lacks something, and that's the dental part of it. That's our realm, as general dentist. So I think we play a big part in the aesthetic, defining aesthetics in the cosmetic surgery world. So, periodontal plastic surgery. No? So again, it's the surgical procedure performed to correct and eliminate anatomic, developmental, traumatic, or maybe disease-induced defects of the gingiva and alveolar mucosa. So I want you to take notice of this. These are the parts because this is a kind of instructional lecture that I'm very sure it's not the procedures are not technique sensitive. I'm confident that all of you listening will be able to do this and will be able to perform this in your practices. So take note of the certain landmarks. Okay, we have the okay the attached gingiva. Okay, the thick one. This is the this is the thick part of the gingiva. This is the hard part where we do the reflection of flaps. No? Above it is your unattached. No? So these are the two main aspects that we must really take notice in performing procedures in perioplastic surgery. Okay, P.D. Miller, no, he coined this. No, he was the one who coined the term perioplastic surgery. Okay, so it addressed the color or gingival color of the gingiva and its defects, like for example, frenum. You know, perioplastic surgery also addressed abnormal gingival margin. It also addressed abnormal gingival display. Now, I coined it, we call it oral plastic surgery because it includes hard tissue augmentation. You know, so these are bony exostosis and the likes. Also involves the pores that are present both in the palate and in the mandible. Okay? And also we deal with oral plastic surgery deals also with emergence profile consideration. So for the GPs who does implants, you know, there. So the emergence profile of the implant is very important. Okay. Well, when you say general practitioner, these are the like I am, you know, I still do fillings, onlays, inlays, dentures, of course, surgery. You know, so that's why it's the general work, you know. So I think general dentists are more of a specialist because we have to know, you know, detailed part of every specialization. Unlike the specialists, no, I mean they're really good in what they do, but they only practice one specialization. So okay, so I hope you really get something out of the lecture because it really deals with a lot of procedures that us general dentists can do. Okay, now let's deal with our first procedure. No, so the perioplastic problems or oral plastic surgery problem that we encounter is the color. Okay, color of the gingiva. Okay, so here at the bottom part you can see this is your amalgam tattoo. Okay, so in the era of composites, you know, call this the nano composites. No? I mean, this is not you rarely see this right at this time and era. Okay, so next you can see this melanin. This is hypermelanin pigmentation. Okay? So of course there is a procedure to do this, and like what I said, it's not technique sensitive. I can confidently say that you can add this to your practice. Another problem is abnormal gingival margin. So you can see hyperplasia of the gingiva. Okay, so that's abnormal gingival margin, and yeah, this is a good friend of mine, Don Don. You can see that the gum recession. Okay, so CT grafting. So okay, so another perioplastic problem is abnormal gingival display. As seen, you can see that this certain patient has a gummy smile. Okay, and the last perioplastic problem is hard tissue. So you can see exostosis. Some patients doesn't want this. Some exostosis are too big that it traps food. So you know, how do we deal with this? and issues with emergence profiles. This is for those who does implants. So the emergence profile is very important, and also involves the mandible, the periodontium. I'm sorry. All right. So start. Okay. First, we classify the types of smile. Okay. So again, we use smiling is a form of communication. We use this every day. You know, without smiling, if you look stoic and silent, I mean, I think the way you communicate with not smiling is different. It's opposite of happiness. So we have three types of smile. First, where the teeth doesn't show, is your commissure or your Mona Lisa smile. Well, as like Mona Lisa, it's a smile without teeth. Next, this is the usual smile that we do. The most common smile that we do when we do our selfies, when we do our when we take pictures, when we take videos. You know, this is the practiced smile or your social smile or Cupid smile. Okay, next is your spontaneous smile or complex smile. This is the smile wherein when you're laughing out loud and someone, you know, randomly takes your picture, you have your spontaneous or complex smile. So this is where everything is seen, the gums, the palate, everything, you know, you smile spontaneously. Okay, so factors affecting the gingival color. This is very basic in our undergrad years. So, and degree of keratinization, the epithelial thickness, and pigments within the gingival epithelium. So, what do we want? Remember, back in the day, we it was taught that the stippling, the biotype is very important. So these are the factors determine the color. Okay? All right. So of course we have a index, no? Dumet et al. In 1964, they did this to for us to classify the pigments, the degree of pigmentation in the gingiva. Okay, the procedure it's called gingival depigmentation. The condition you have is melanin pigment hyperpigmentation. Again, okay, the condition that we have is called melanin hyperpigmentation. So the procedure to manage this is gingival depigmentation. So clinical melanin pigmentation is completely benign and does not present a medical problem. Okay? So demand for cosmetic therapy is made, especially by fair-skinned people. Okay? So usually with gummy smile patients, we see this, you know, and sometimes they think that the treatment for this, they go to doctor, I want to have braces. Usually that's the things that we hear in our practice. Doc, my gums show so much. Can you put braces or can you put veneers? You know, I think it's such a waste of veneer material and the procedure. If you put veneers in, you know, a case that you know can be handled with your periodontal management. So again, gingival depigmentation is the periodontal plastic surgical procedure whereby the gingival hyperpigmentation is removed by various techniques. Okay, okay. This is a technique that I want you to bring home after this lecture. You know, this you can do this actually. If you can handle a scalpel, you know, if you know how to peel actually a kiwi, you know, it's just it's the same. The principle is the same. Okay, so in the scalpel used for okay, partial thickness. Okay, so for a while. So when you say partial thickness, sorry, this is where you leave periosteum when you do flaps. So we have full thickness. Full thickness includes the periosteum, and partial thickness you leave the periosteum. Okay, I want you to see this. Okay. Okay. So here the preoperative radiograph showing gingival pigmentation. Okay. Okay. So it involves surgical removal of gingival epithelium along with a layer of underlying connective tissue under adequate local anesthesia. Well, of course, you anesthetize here in the vestibule area, with lidocaine. Okay. The secret, guys, I'm telling you, the secret in profound for the anesthesia to work, for the epinephrine to work, for your hemostasis to work, is it's you do it in slow motion. Inject slowly, very very slow. Like it's like when we instruct children to brush their teeth. They sing 2 songs. So it's like that. Don't rush it. Don't push the syringe like you're irrigating. No, that's very wrong. For the epinephrine to activate, you do it in slow motion. You'll be amazed that when you do your incisions, there will be no blood. Okay, so using your 15 blade, okay. So you prepare around for okay, because sorry, because the aesthetic part of this is the aesthetic zone. That's the area that you're gonna address. You prepare around four to five scalpel number 15 blades because it's easily uh, it easily gets dull. So it's like peeling. You're filleting. So you're filleting the gingiva. How will you know when you're doing the right thing? You use your gauze. You just dab. You just dab the gingiva and you see if the pigment is still there. You will see the pigment. It's brownish. Fillet more. It's a filleting action. You don't scrape it. Don't scrape it. You have to fillet that certain layer where the melanin is. Okay, that certain strata where the uh, melanin is. So you'll see if it's pink. When you dab it with the gauze, it will turn pink, and then suddenly blood will rush up. So if you see all is pink, so that's good enough. Now you might be asking, Doc, what if we reach the bone? What if we are in the bone level? Will it affect the bone? Will it infect the bone? No, because you didn't know. The answer is no, because you didn't raise a flap. You didn't raise the epithelium. Okay, so the epithelium is still intact. It's okay. Okay, so you can see the before and after. Next, so it's like this. You fillet it. You just fillet it. So it's really gonna bleed. That's why hemostasis is very important here. Okay. Well, after this, literature says that you might be asking later, doctor, will we place a periodontal pack in procedures like this? Personally, it depends on you. But me, in our practice, we don't um, put periodontal packs for just one reason, because it's hard to clean. When the patient eats, whatever it is, like soft diet, liquid diet, um, definitely food debris will go inside. It's really hard to clean. Um, Again, you do your partial thickness flap here, and this heals by secondary intention. Okay, so it's just like fillet. You fillet it. You slice. It's like filleting. So here, one of our patients in our workshop. So you can see the difference. This is actually around 2 weeks of healing. So you can see a big difference from before and after. So patient is happy. Okay, this is another procedure that, as general dentist, I'm encouraging to do, because like what I said, this is not technique sensitive at all. Okay, again, the objective here is to reach that certain stratum layer of epithelium where your melanin is, where it's located. So it involves removing the epithelium of the pigmented areas with a high-speed handpiece, using a diamond burr. Sometimes we use the acrylic burr, the low speed, the white stone. Okay, so it is recommended to use the largest size diamond burr, suitable and following the feather-like brush stroke. So it's like erasing, slightly erasing a pencil mark. Okay? So to remove the pigmented areas without holding the burr in one place, it has to move, and your control, your finger rest is very important. Suddenly you may, it's, remember, you're using a high speed, and it could really do injury. Okay, but well, technically speaking, the procedure involves injuring the epithelium. Okay, so dependent on the extent of the procedure, the denuded lamina propria of the depigmented areas may be covered by a surgical dressing. Again, it's your option if you want to use a periopack or not. So you can see before and after using a burr. Okay, let me show you the procedure done, how you will use your burr. Just light strokes like this. So this is courtesy of Dr. Pocholo Loleng. Thank you, Dr. Pocholo. He's one of our associates in the workshop. So one of my partners. So copious irrigation, of course, given that you did your hemostasis properly, okay, you see the bleeding, it's very minimal. Okay? So again, so actually the if you place your index here, this would fall around 1 or 2. It's not that the melanin is not that significantly dark, but the patient is actually concerned about that pigmentation, the brown stains. We were actually concerned about her gummy smile, but she wanted just the pigments to disappear. So with what the Dr. Lolling was doing a while ago, so you can see the difference from the right portion to the left portion. This is doing it. This is the surgery day itself. Okay. So sorry, this is betadine. Okay. I don't know if you prep your patients, but in doing oral surgery procedures, always prepare your patients. With a sterile area using you prep it using betadine. So here is she now. So let me zoom that in. There, no more pigment. Very clean. Okay. Okay. Well, I'd like to commend the previous speakers who discussed about lasers. I think it's the future of dentistry. So, but I'm certain that most of us here, most of the general dentists, have no have no laser machine. So, but I'm going to show you that laser can also be used in depigmentation. I think this was discussed by the previous topic in lasers. So there. So this is the preoperative situation. Okay, so use of the diode laser. So post-operative and 1 week post-operative, it looks normal and patient is happy. Okay. Clinical considerations. So later I will give you guys my email. If you have, if you want help in your future cases, you can email me or Facebook me. I would gladly help you with your future cases. So I encourage you to incorporate this in your practice. It's not technique sensitive at all. Okay, and it adds up to the aesthetic quality of your, for example, veneers or bridge. So to ensure treatment success, the potential cause should be identified. In every treatment, of course, we have to know the cause, the etiology. All the remnants of the melanin pigments areas of the veneer should be completely removed to prevent possible relapse. Okay. So spontaneous repigmentation might occur due to activity of migration of melanocytes. In our experience, none has come back, but literature says that it may come back. But remember, you have to address all the pigments. You have to address it. Okay. Now we go to our abnormal gingival margin. Okay, so please take note of this landmarks. Okay. So again, this is the marginal gingiva, attached gingiva, and unattached. This is very important because this will be our landmarks later in doing our lip repositioning and aesthetic crown lengthening. Okay, this is actually an undergrad topic, but I think it's very, very important that every dentist should know, every general, even general practitioner should know our biologic width. What is biologic width? Okay, so biologic width is the space that it's like no entry zone. It's like the yellow tape that the police place when there's a crime scene. So you cannot enter there or they will sanction you. Okay, so it's like that. You cannot cross that space. So sorry. The biologic width is the space, no, between the base of the sulcus. Connection between the tooth and the gingiva is mediated with the junctional epithelium. So that is your biologic width, this one. Okay? From here to the bone. Okay. So, well, in doing your preparations, you cannot impinge this area. Okay. Common sense will tell us that when you let me the pointer. Okay. So of course, common sense will tell us if the restoration reaches here, inflammation will surely occur. So from this point to this point is your biologic width. You cannot cross that. You cannot touch that from here to this part. Okay. So that's very important in the procedures that will follow. No? So that's your biologic width. Okay, again, okay, gingival hypertrophy or enlargement, because we're dealing with our sorry, abnormal gingival margin. So first, we should know the etiology of this. Okay, some of us may do gingivectomy, may do gum sculpting using our call this cautery machines. You know, we shape it. Well, actually, that's okay. That's okay to do, but we have to know why this starts in the first place. So, okay, some are drug induced mostly, but I think now, yeah, mostly it's drug induced or sometimes it's irritation induced. No? Irritation fibromas it looks like this. So we have to know what causes it, because if not, you know, it will just come back. So doing your cautery would be no use. Okay, so gingivectomy. Okay, well, you'll appreciate more of gingivectomy in this presentation. So this is where we use our blade or our cautery machine to sculpt, you know, excess gingiva, thick gingiva, thick biotype gingiva, flabby ridges, you know, if needed. Okay, so it's indicated in the elimination, of course, of suprabony pockets, gingival enlargements, and suprabony periodontal, you know, abscesses. So when we do our crown lengthening, so we have two types of crown lengthening: our aesthetic and our functional. So this is very common where we just use our blade. And remember, genetically, the patient is born. So if it's not drug induced, okay, if the enlargement, if it's not drug induced, if your patient has a thick has thick gums, remember genetically he is designed to have this. So cutting your gingiva will just, you know, it's just like cutting hair. It will grow back. So you have to address that going back part of your gingivectomy. Okay, gingival recession. Before we go into that, the crown lengthening, let me discuss about gingival recession. Of course, again, we have to know the Miller's classification of gingival recession. Okay? Your class 1, 2, 3, and 4. Okay? So knowing this would know the prognosis of your treatment. I'm not really encouraging you to do this. This is the most technique sensitive of all procedures discussed. But in any skill, actually, repetition. I'm not saying that you practice on your patients, but if you have friends, you know, or colleagues who has receding gums, I mean, you can, like in our workshop, we really brainstorm on this. I like I'm still a student, work in progress. I'm learning every day. Every day we conduct our workshops, I'm also learning. So, like what the saying says, repetition is the mother of all skill. So, you just, but like I was saying a while ago, this is the most technique sensitive of all discussed today. Okay? So the surgical steps in your subepithelial connective tissue graft. Okay. Hi. Okay. Okay. So CT grafting or okay, your subepithelial connective tissue graft. So this is to address your gum recession. Okay. Okay. So this is how you get your connective tissue. This really takes practice. I have to admit, the first two or three patients that I did this actually failed. Well, it's really frustrating because the thickness of the connective tissue should be sufficient, enough to be for you to use it. But anyway, it's a matter of practice. So you get your connective tissue from the palate. It's in the area of your premolars. Okay, why there? Because the back part of it is your innervations are there, and the front part of it, your incisive region is there. So it's in the back of the premolar areas. Sorry. Okay. This case, actually, our students, our participants did this. Okay. As you can see, um, this is a receded case, a Miller class 3. Okay. Okay. Also, you can see there is a composite restoration there. Okay. Well, our gingiva, it doesn't, it's really not. I don't know. Correct me if I'm wrong, Dr. Arki, who's tuning in. No? Because composite has methacrylic. The byproduct of composite is methacrylic acid, wherein gingiva is really not, compatible with it. So you have to remove that. Okay? What we did again, we prepared the root, with EDTA. Now you could use EDTA. So in literatures, they use citric acid. So with that, you just scale with your Gracie curette. You scale this area, the root area. Okay, and of course, prior to everything, you do your oral prophylaxis. Okay? And then here we used the sorry. We use the piezo, the woodpecker piezo surgery machine to remove the composite because we don't want to damage. The burr will only, excessive damage will occur if you use your burr rather than if you use this. It's really precise, it really takes out the composite and without damaging the dentine. Okay, so this is how we use this. And with just that, you remove that thin layer. Okay. This is the first day of the surgery. Remember, this was done by first timers. Okay, first timers. Okay. So this is 1 week post-operative. You see it's starting to merge with the surrounding gingiva. Okay. This is 2 weeks. You see it's becoming one actually. Sorry. Oh, sorry. This is 3 weeks actually. 3 weeks post-operatively. So you can see, attachment occurred. Attachment occurred. So I think we haven't seen the patient yet since then. But yeah, with this state, the patient was very happy. And again, I want to reiterate: this was done first time, by our participants. So if they can do it, I am pretty sure everyone can do it. Okay, this is one of our work long time, around 7, 8 years ago. So you see a class 2 Miller classification. So we got the connective tissue from the palate, and nowadays there's a lot of techniques, the tunnel techniques, but this was old school. So we did a split thickness flap, okay? Cut it in the middle and there. So this is one of the first procedures that I personally done. So it was, I think it was at at par. It was not excellent, but yeah, it can do. 10 days after, at least there's a thick tissue, there that you can easily do gingivectomy. That's why I'm telling you this particular procedure is it's the most technique sensitive of all. But I'm not discouraging you not to do it, but just repetition. That's what I'm saying. Repetition is the mother of all skill. Okay, now we go to the main topic of the periodontal oral plastic surgery lecture. So the gummy smile. So it's also called your excessive gingival display. So it refers to the individual suffering. Sorry. Okay, individual suffering from an abnormal gingival display. Actually, from this point to here, if it's above 3 millimeters, well, that's a excessive gingival display. Okay, not all gummy smiles are the same. Well, this is my daughter, my lovely daughter, who has a cute gummy smile. Okay, but yeah, not all gummy smiles are the same. Okay? It differs, this procedure actually is one of the procedures that one of our favorite procedures in the workshop that we do, and we encourage everyone to try this. It's not, again, the difficulty level out of 10 is around 5, 6. I think everyone can do this. So etiology is very important. The cause of the gummy smile of anything, actually, when we treat disease or in surgery, we have to know the etiology. So different types of gummy smiles are, well, facial proportion, short lip, hypermobile lip, and tooth proportion. Okay. Let's discuss each. Okay, remember a while ago we were following the journey of patient 1, 2, and 3. So vertical maxillary excess. If you divide the face of the patient into 3 equal parts, okay, 3 equal parts, it wouldn't be with closed in the rest position. No? With vertical maxillary excess, it wouldn't be even. So here you see there's an overdevelopment of her maxillary jaw. No? Okay, what are the possible treatments for this? Orthodontic surgery. Okay, well, it's as general practitioners, this is out of our realm. We refer this to maxillofacial surgeons. Okay, the morbidity is too high. Post-operatively for the patient, it's very painful. Number 2, lip repositioning. In doing lip repositioning with patients who has vertical maxillary excess, or for the orthodontists who are watching, the patient who is very retrognatic, the severe skeletal, if I'm correct, I'm not an orthodontist, but the severe class 2 patients, so those patients, actually, lip repositioning is contraindicated. Okay, so the mere fact of smiling, when the patient smiles with that condition, it really pulls. If you do your lip repositioning in those patients, remember, you're dealing with epithelium, and epithelium is elastic, so it will fail, it will relapse. Okay, again, another treatment is aesthetic crown lengthening. Well, I think it's not enough, or a combination. Okay? So for vertical maxillary excess, again, this deals with the facial proportion. Okay? Now next is your short lip. Okay? So short lips are the decreased height of the upper lip, usually arched. These are the people when they smile, the upper lip is arched. Okay, so 4 millimeter gingival display when smiling. So this is common in female, the short lips. So that's why actually gummy smiles are more common in female than in male because of the short lips. It's more common in female. So Botox, one treatment that we can use. Well, the downside of Botox, actually, I want to study Botox. I think it will be a good arsenal in our dental practice, because Botox will, I think also in TMJ, in TMDs they use this, so it has potential. So Botox, the problem with this is your body gets immune. Of course, it has a lifespan. No? It's like whitening; it doesn't last forever. Another treatment for this is lip repositioning or combination of both. We will show you later what we did. Okay, this is the patient a while ago who had her depigmentation. So hypermobile lip. So patients with hypermobile lips, these are when they smile, you see that it's really wide. It's really wide. So lip movement upon smiling is 6 to 8 millimeters. The movement is 6 to 8 millimeters. Now, that's the normal. A hypermobile lip is 2 times the normal. So it's around 16 to 22 millimeters. Okay, another. Okay, hypermobile lip. So again, treatment is lip repositioning or aesthetic crown lengthening or combination of both. So lastly is your tooth proportion. So as you can see here, this is what you call orthodontist, if they're familiar with this, is your altered passive eruption. Normally in our practice, people with gummy smiles like this, they tend to seek orthodontic help. Actually, orthodontic therapy, I forgot to mention, is also an option, but it really takes long for you to intrude, if I'm not mistaken. So again, altered passive eruption. So your options are aesthetic crown lengthening and lip repositioning. Okay. Okay, so let's define lip repositioning. So lip repositioning is defined as your surgical way to correct gummy smile by limiting, remember, limiting the retraction of the elevator smile muscles. Your zygomaticus minor, levator anguli oris, orbicularis oris, and your levator labii superioris, and yet preserve the labial frenum. Okay, this is a schematic diagram of your elevator smile muscles. Okay, so let me just point it out to you. Okay, I want to say hello to the SIDS participants, the SIDS family who are watching now. Hello. Okay, so again, this is the elevator smile muscles. Your orbicularis oris, okay? Zygomaticus minor, major, and labii superioris. So pay attention because the procedure will entail manipulating this. Okay, this was the patient a while ago. Remember patient number 1? Actually, I think she's watching now. She's a dentist, Dr. Viloria. Hello. So she's a dentist. She's one of our patients who volunteered to have her lip repositioning done. Okay? Her history, actually, she really didn't like her smile. She was bullied as a kid. The usual, things that people with gummy smile encounter. This is her. This is, and for the information of everyone, all the patients here allowed us to show their, faces. So there. So Dr. Viloria had a smile. So usually, like what I said a while ago, this is the second type of smile. that gummy smiles usually do. It's a controlled type of smile. But when they do their full smile, here you can see the gingival display. You can see her crowns are really short. Okay. Again, this is patient number 2 a while ago who had the maxillary excess. And patient number 3. So all of them were candidates. Okay, kudos to Dr. Judith, one of our loving students and participants. She's watching now. So she was the one who managed this. So I'd like to showcase her work and show it to you guys. Okay, so the facts. So a lot of articles online about 104 publications are present in the internet, but no conclusive literature. Okay, most are just techniques done in its description. So, and all are short-term studies. There's really no journal. Randomized studies that proves how it works. How lip repositioning works. The long-term effect of this procedure. Okay, but I'm happy to tell you that there is one study of all the 104 that actually we found that really works. Okay. So randomized clinical trial by Lumiere et al. 2016. The procedure included with myotomy and without, and I'll show you how they did this. So with myotomy worked. Without myotomy, it recurred. So it just returned back to its original condition. Okay, this is how we do lip repositioning. Okay, first, of course, again, given the correct instrumentation, again, this is not an instrument lecture, but I really encourage everyone to have the correct instruments when doing your surgery. What are those? Your mucoperiosteal elevators, your curettes, your what you call scalpel, your blades, everything. I'm sure you're familiar with gum separators. It's we were I personally was taught that it was a gum separator back in the day, back in college. So this is your Woodson. It's called a Woodson instrument. Woodson plastic instrument. There's no such thing as a gum
and control. If there are oral emergencies such as maxillofacial trauma, significant maxillofacial swell, tooth trauma, continuous severe toothache, what are the steps to keep you safe during the consultation? Clinical reception procedures. Make an appointment in advance. Medical staff wear masks and goggles. 1.5 meters apart when queuing. Full body disinfection, including clothes, shoe sole, and hand disinfection. Measuring body temperature, fill in the travel history, medical history. Clinic air disinfection, one patient, one consulting room. Respectively prepare disposable foods, dental barrier foam, oral instrument boxes for each patient. Disinfect consultation room, sterilize instrument with an autoclave sterilizer, and spray disinfectant on the ground. During the period of epidemic prevention and control, if there are oral emergencies such as maxillofacial trauma, significant maxillofacial swell, tooth trauma, continuous severe toothache, what are the steps to keep you safe during the consultation? Clinical reception procedures. Make an appointment in advance. Medical staff wear masks and goggles. 1.5 meters apart when queuing. Full body disinfection, including clothes, shoe sole, and hand disinfection. Measuring body temperature, fill in the travel history, medical history. Clinic air disinfection, one patient, one consulting room. Respectively prepare disposable foods, dental barrier foam, oral instrument boxes for each patient. Disinfect consultation room, sterilize instrument with an autoclave sterilizer, and spray disinfectant on the ground. Clinical reception procedures. Make an appointment in advance. Medical staff wear masks and goggles. 1.5 meters apart when queuing. Full body disinfection, including clothes, shoe sole, and hand disinfection. Measuring body temperature, fill in the travel history, medical history. Clinic air disinfection, one patient, one consulting room. Respectively prepare disposable foods, dental barrier foam, oral instrument boxes for each patient. Disinfect consultation room, sterilize instrument with an autoclave sterilizer, and spray disinfectant on the ground. During the period of epidemic prevention and control, if there are oral emergencies such as maxillofacial trauma, significant maxillofacial swell, tooth trauma, continuous severe toothache, what are the steps to keep you safe during the consultation? Clinical
Okay. So, hello. Sorry. Yeah. Can you hear me? Okay. Wait for a while. Sorry about that. Okay. Sorry about that. Let me just. Okay. Sorry about that. Okay. Okay, guys. So sorry about that. There was a connection problem. So I think it's because of the ECQ. Suddenly the connection got cut. But anyway, let me go back to that slide that we last. Okay, so yeah, we were talking about lip repositioning. Okay, so again, okay, so we measure the. Okay, can you hear me? Okay, wait, it's lagging, I think. Okay, so we measure the gingival show first. We first measure the gingival show. Okay, okay, and then remember I told you to pay attention to this diagram because we will be really using these landmarks in doing the lip repositioning procedure. Okay. All right. So this area, this is the mucogingival margin. Okay. So this one. So this is where the unattached and attached gingiva. This is where they meet. Okay. In lip repositioning, like what I said, you will reposition the lips downward, no, coronally. So again, this line, the dotted line indicates the area where you're gonna strip off you're gonna use you do a split thickness flap to remove it. Okay, so the margin is your landmark. So you incise here, you know. So okay, this is not an even incision. You know, you should follow the where the attached and unattached gingival margin meets. Okay, so it looks like this. Okay. So this is given that you did your anesthesia, you did your hemostasis. Again, the secret in good anesthesia is slow motion. The secret also in good incision is you do it slow motion. You know, like really, my mentor actually called it surgical grace. You know, you should, when you do your surgery, it's like dancing. You know, so the first time dancers, you'll see them really dancing awkwardly and not without finesse. So you practice it in slow motion. You incise with a slow stroke, you know, continuous stroke. Also, your injection should be slow and steady. Okay. Also, again, the secret in suturing is also that slow motion movement. For you to be fast, do it in slow motion. So ironically, that's the secret. Okay. So again, the incision will be here in your mucogingival margin. Okay. So you make two incisions. Okay, there are two types of techniques in doing lip repositioning. One that includes the frenum, that's your standard lip repositioning. It also deals with the frenum and does a frenectomy with it. But personally, I don't like touching the frenum because number one, it's one of your landmarks. It's one of the midlines. You know, let's say your patient encounters an accident, his nose, tips to the right or is not in the center anymore. At least you still have your frenum to guide you with your midline. So again, sorry, we do both. Sorry, both incisions, left and right, and we preserve the frenum. Okay, this height. Okay, listen carefully, guys. The height of this one from here to here. Okay, it's usually 10 to 12 millimeters. Remember, 10 to 12 millimeters. It's double. Okay, how will you know if you for some reason forget that it's 10 to 12 millimeters? Okay, the length, the distance from the margin from here to the epithelium is double the distance of the gingival that is shown. Sorry, I'll go back. So double the distance, double this distance. So for example, this is around okay 5, 6. So this is 6. He measured 6. So from the margin to the epithelium, you measure 12. Okay, if you forget, but don't exceed 12, 13. Don't exceed 14. That's too much. So the distance between the gingival margin to the epithelium is around 10 to 12. So again, you make an incision from the midline until, okay, where will it terminate? Until the mesial part of the first molar. Okay, again, when you cut, okay, you cut 90 degrees to the bone here, okay, until the mesial part of the first molar. So that goes to the other side also. Here to the mesial part, it terminates in the mesial part of the first molar because that's where the labii superioris terminates. Okay, and then you measure 12. So there, you make a flange here and preserve the frenum. Okay, so next is you do a split thickness. Split thickness, you remove that portion using a split thickness type of incision. Okay, so holding your tissue forceps, you just slice it. Slice the epithelium, the fibers. Okay? So it's just like removing skin. Okay? Grasping the epithelium, that certain measurement that we did. Okay, so you do it in both sides, and then this is how it looks like. So as you can see again, I'll repeat. We review the procedure from the mucogingival junction here, okay, until it terminates to the first, the area of the first molar, the mesial of the first molar. Okay. So again, another technique when you do this, okay, also when you measure it, it has to be stretched. Don't measure it relaxed. No? You have to stretch the tissue. Also, when you're cutting for ease of cutting, you have to stretch the tissue. Okay. So here we preserve the molar. Okay. So here you can see the muscle fibers. This is your oris. Sorry about the pixelation or the quality of the photo. This is what I'm trying to perfect now, to study now, correct dental photography. So I'm really sorry about that. But anyway, when you perform this, you will see fibers. You will see fibers going along different directions. So there are oblique directions. There are vertical direction fibers. So you'll know that here in front, this is the orbicularis oris. So you'll see the fibers going here. This is your zygomaticus major and minor. Okay, later you'll see it. Okay, so when we reach this step, Okay, you remember, as you can see, the bleeding is controlled because we're in the fascia. We're in the fascia area. Okay, you can see the fascia, and because of like what I said, the slow motion in depositing your solution, you create a very good and stable hemostasis. Okay, okay. This is actually a while ago we discussed myotomy or without myotomy. In their study, okay, the first few lip repositioning procedures that we've done in the workshop, actually, without manipulating the muscle, actually, I'm sad to tell you, it failed. Okay, if you only do this and then sorry, and then suture it because you're gonna pull it down. Sorry, can you guys see it? Wait, there. Okay, when you suture it without manipulating the muscle, okay, and you only do this, okay, believe me, I'm telling you, it's a failure waiting to happen. Okay, because remember, you're dealing with epithelium, and epithelium um, is elastic. One of its characteristic is it's elastic. The patient smiles often, it stretches it. It's a failure waiting to happen. Now, randomized testing was done and said that myotomy was done. So in those procedures, they cut the elevator smiling muscles. Okay, they cut, but you know it's too morbid, and it's either you restrict the that movement. The smile becomes unnatural because it's too stiff. When you do myotomy. So what we did, there was this I was advised actually by a friend of mine, Dr. Makasiray and Dr. Pangan, to manipulate the muscle. And when we were doing this, several months after, I found a journal stating this. No, so you manipulate the muscle by bundling it. No, so it restricts its power. So here you can see, no, so these are your minor salivary glands. So it's normal. So it's perfectly normal. So that's okay if you see those. It's normal. So here you can see the orbicularis oris muscle. So you snatch, and then what we do is like doing a ponytail. You bundle it. We bundle it, so it restricts its action. It's like four people. Imagine four people standing beside each other together, uh, will lifting a board, or a big or a bar, okay, a heavy bar. When they're standing equally, beside each other, they can easily lift this. But if you tie them, if you bundle them, if you tie them, if you restrict their movement, their strength, it will take a toll for them to carry the platform or the bar. So again, you ponytail it. So there are actually one, two, three. Okay, one, two. Okay, four muscle groups involved. No? Your oris, your zygomaticus major, minor, and the labii superioris. So I will show you. No? So you bundle it in such a way, and then just it doesn't matter if you get the whole. It's impossible to grasp the whole thing, the whole muscle. Okay, so you just restrict its movement. So to show you how it's done, this is a little This was done by our participants. So there, as you can see, I'm sorry about the. This was amateurly taken. No, the video was taken by an amateur video. So you can see that there the fibers. No, you'll see it clinically. You will see it. The fibers are being bundled together, to restrict its movement, to restrict its function. Okay, so there. You just bundle it. It's like doing a ponytail. All right. So this is the secret of a good prognosis in your lip repositioning. Doing bundling your muscles. So this is the groups. Okay, so first, let me. I think it's lagging. So all right. So there. Um, as you can see, the first muscle group that we bundled is your. This is your orbicularis oris, and then you'll see strands here. Your sorry, it's only five muscle groups. The labii superioris here. Well, it doesn't matter because it's far from the gummy smile area. So you only bundle this five muscle groups. So black, this both are the same. So this is your zygomaticus major, and this is your zygomaticus minor muscle. Zygomaticus major, zygomaticus minor, and these are orbicularis oris. So it's like curtains that you just bundle together, restricting their movements. And I guarantee you with this, those randomized trials that in the internet that has been done. So with this, we have actually our first more than 1 year patient, and it didn't recur. The condition didn't recur. So let me show the patient to you. So after that, no, after this bundling. So again, the suture you're going to use, of course, must be a resorbable suture. Okay, underneath here. Okay. Of course, you're going to leave it under, so you let it resorb there. So, and of course, interrupted suture is done. You can do your continuous, but sometimes if it's not properly done, one nick in your continuous will the it will continuously break also. So might as well do a continuous sorry a what you call it's your normal surgeon's knot suture, no. So what you call this? You just and then irrigate with saline after. So healing of this will take around, well, because you dealt with muscles and this heals slower than your normal epithelium, around 2 weeks. Around 2 weeks. Okay. So you can see the finished product, no. So this was taken actually around 3 months after. So there's no relapse yet. Let me show you the others. Sorry, 6 months post-op. 6 months post-op. Okay. This is Dr. Viloria now. This was her before. So she had the same type of smile. The third type, okay, of smile here and here. Okay. What we did with Dr. Viloria is a combination of lip repositioning, and after when it healed, we did a aesthetic crown lengthening, which I will be discussing after this. Okay. So it's a combination to expose the hidden jewels that was hidden underneath her gums, her gingiva. So before and after. Again, doctors, I'm telling you, this is a 1 year post-op picture of the patient. Okay. So I'm telling you, in manipulating the muscles, in binding them or in bundling them, you restrict their. So what's going to happen? It's like you're injuring them inside. So it's going to heal in that certain pattern that it's bundled. So the movement is restricted. So, okay, this is the 1 year post-op of this one. Okay, again, this was done by Dr. Tutanes. Okay, I think she's watching now, so you can see the difference post-operatively, and I think crown lengthening will also be done. But yeah, you notice the difference. I've noticed the lipstick, but also, of course, the difference in the smile. Okay. Okay, this was done by Dr. Judith. Okay, so this was the patient. Sorry, wait, sorry. Let me. Okay, this was patient number 3. Okay, so 5 weeks post-operative. Okay, another side effect of lip repositioning. One side effect will be the scarring. There will be a scar. But of course, you won't be able to see that scar. You know, when the patient smiles. Another will be it's actually a good side effect. Notice that all of the patients, okay, prior to everything had thin upper lips. For some reason, no, when you do lip repositioning, the upper lip thickens. So of course, the ladies, you know, the female patients love this. So notice here, thin lips prior, and then thick lips with red luscious lipstick after. Also here, you know, the pre-op picture is here. So here, this was her picture before. Okay, kudos to Dr. Judith for doing a good job. You see the lips is thinner before than after. So the smile that she's doing is the same. So no more gingival display. Okay? So patient's happy. Yeah, patient number 3, 5-week post-op. See, look at the thickness of the lips. This is one of the side effects, the good side effects that we want in doing lip repositioning. Okay, so we go to aesthetic crown lengthening. Okay, so crown lengthening is indicated for aesthetic reasons, no, to correct either a gummy smile or gingival overgrowth. Again, we have to know the etiology or the root cause of the disease. Okay, it may be also indicated for restorative reasons. Increase the crown retention, exposure of subgingival caries or fracture, raising in the restorative margins by increasing the amount of sound tooth structures above the alveolar crest. Again, I was stressing a while ago the importance of biologic width. Never, okay, violate your biologic width. You will have problems, believe me. So remember, when there's inflammation, there's resorption. So when there's resorption, there's problem with aesthetics and, you know, so on and so forth. There's a domino effect, a cascade of problems if you violate your biologic width. Sorry for this. So here, we only did you see her gummy smile. Sorry, I photoshopped it because this is the only picture we got of her without the face. But the after picture of this is her post-op after the aesthetic crown lengthening. So when we do in our practices, when we see patients with gingival overgrowth, we're so excited we get our cautery machines and just cauterize away. Actually, this will regenerate back. Remember, the patient is genetically designed by the mom and dad, by the Lord, to have this type of gums. No, so if you don't manipulate it properly, the gums will, with cutting just the gums, it will return. Okay, in aesthetic crown lengthening, we reduce the bone. All right, so here we only did an aesthetic crown lengthening. We didn't do a lip repositioning. I think we also did a depigmentation, but no lip repositioning. So this is post-op. Okay. So you see, sorry. You see here, let me zoom it. It seems that lip repositioning is needed because if you measure, there's around well at least 3 millimeters of gingival shown, but we only did aesthetic crown lengthening. So how do we do aesthetic crown lengthening? So again, we respect the biologic width. Okay, so again, to show the biologic width, it's this one. It's the area with the connected epithelium to the area of the bone. So that area, okay, we measure, we use. That's why the periodontal probe is very essential. You have to have a quality periodontal probe in your arsenal. Okay, I want to run through this very quickly. This is your choose aesthetic proportion gauge. Well, like a musician, like a musician, sometimes the musicians they play their pieces by ear, but they just listen to it and don't read their notes and they play it. It's like dentists. When in the aesthetic world, we're like an artist. We do anatomy. Uh, Dr. Arki, a good friend of mine, very good in restorative and aesthetic dentistry. He's really particular with the anatomy, with the color. So in the sense that I'm saying this, no, we're artists that we're no different from the musicians and the artists that we see in our community. So sometimes we work by eyes. We work using our eyes. We work using our feel. But there's a instrument to actually address address this and for us to be exact. Sometimes when we do our veneers, direct veneers, like what I said, we use our eyes. We just use our feel, what's beautiful for us. But with using this choose aesthetic proportion gauge, we're precise in what we're doing. It gives you a precise measurement and the ratio of the correct width length of the crown. Okay? Also, it deals with the correct length of gingiva that you have to reduce. So here, let me show you. So this gauge, okay. For example, here where the red vertical line touches, the red horizontal line should be there. So if the gums are below that, you cut that. So this is how to use this gauge. It's very user friendly, and a lot of our students will purchase this just for the, I mean, because their patient influx is more of aesthetic. So if you do a lot of aesthetic work, veneers, um, post implant restorations, I think this is an integral or important instrument that you should use. Okay, again, okay, in doing, again, before I show the procedure, this is the tips that we use in doing our, the piezo tip in doing our crown lengthening procedures. And osteotomy, sorry, osteotomies. And actually, this is for sinus, no? Anyway, sorry. Okay, so this is where I'm sure the aesthetic dentists that who are watching knows this, no? The pleasing width length proportion, it's supposed to be 75 and 80%. Okay, so with using that gauge, you will be able to produce this type of ratio and proportion. But sometimes we have patients, because of the advent of beauty pageants, mostly here in the Philippines, sometimes they really want big white, bleach white colored, really big veneer. So, well, it's up to you. It's your own. Some dentist doesn't fall into this, but what we do is we let them sign a waiver that it's not the prescribed treatment. So I think we should have that. It's a document that aids us in our legal side of our work, because sometimes some patients are too pushy that they really insist on you to do wrong dentistry. Okay? So again, here where the vertical line lies, the horizontal line should touch that. So for it to be proportion. So it's called a choose proportion gauge. So the T-bar, okay, there, sorry, it's for here, sorry. The biologic perio gauge, this is to preserve your biologic width. Again, I was stressing a while ago that the biologic width is very important. So what you do, the horizontal line here, where it lies, where it touches, it should, the corresponding red horizontal line should touch. So this is where you cut. This is where you incise. Okay. So maybe you'll be asking, can I use laser? Can I use You can use anything as long as the principle is correct. Okay, it's like doing it's like using your forceps for extraction. Can I use this? Can I? As long as the physics is correct, the philosophy, the principle, that's why we have principles in surgery. That it's a must to follow this. So in doing your incision, you can use anything as long as the principle is correct. Okay, so now we do the step by step in doing our aesthetic crown lengthening. So when you say aesthetic crown lengthening, of course the aesthetic zone is involved. Okay, let me zoom it. Sorry. Okay, so here we see aesthetic reasons. It's not they're not in the. We were taught in undergrad, that the certain height, the height of the central incisors is the same with the height, the zenith of the canine. This is a little bit lower, so we have to follow that in aesthetics. I'm sure the aesthetic dentists who are watching could follow. So in doing this, first first incision that we do is your 45 degrees incision. Okay, here you have to okay, given that you've determined your biologic width, you use, for example, your true perio gauge. Okay, what we do is we cut. Okay, we incise. So it should be 45 degrees. Remember, it should be beveled, not 90 degrees. Okay, the angle of the blade should be 45 degrees. It should be, wait, let me stress that out because that's very important, guys. Sorry. It should be like this, 45 degrees. Okay, 90 degrees is like this. So we do a 45 degrees. Okay? This is what we do. It has to be beveled. Okay. After doing your 45 degrees, so you've sculpted this 45 degrees, okay? 45 degrees, 45 degrees. For example, this, sorry for the it's just an example, okay? Okay, after that, you do your sulcular incision. So you insert the blade underneath here. So the blade will be underneath here. Sorry. Okay. So sulcular incisions. And then using your Gracie curette, just curette the cut portion down. Okay. When you, after you curette the cut portion down, okay, pay attention. This is very important. No? You do a papilla preservation flap. Okay. You do an envelope flap, but you preserve the papilla. Okay. Sorry. Wait, let me erase that. Okay. So what's a papilla conservation flap? It's this one. So you preserve the papilla. So as you can see, the papilla here are preserved. Okay. Why do we do that? Before raising an envelope flap. Remember, an envelope flap is a flap without releasing incisions. You don't have that corners. It's just like a pocket or an envelope. Okay. But this is important. You don't include this. You don't include the papilla part. You don't include this part. Okay, why? Every time you make an incision, as a sulcular incision or an envelope flap, every time you suture it back, this recedes around 0.5 millimeters to 1 millimeter. So, given that this is an aesthetic zone, you will produce black triangles if you include this. So, don't include that. You just make a straight incision here and then raise the flap. Okay, so given that you understood that, let's go back to our aesthetic crown lengthening procedure. Now, using your perio probe, measure 2 millimeters. 2 millimeters from the cemento enamel junction. Okay, so 2 millimeters from there, you reduce bone. Okay, remember, gingiva, where the bone goes, the tissue will follow. So it's just as simple as that. No? If you reduce that, if you thin that out, of course, the gingiva will follow that. The tissue will follow whatever bone. Hi, Clara. Okay, so whatever bone you reduce, the tissue will follow that. So that's very important. And I assure you, in doing this, it won't grow back, right? Like like what we have done in the past, using the blade or the cautery, we just cauterize away, and then after 2, 3 months, 4 months, patient comes back, the tissue, the gingiva returns to the same how it was before you did the procedure. And then here you can see, okay, oh, it's raining. Sorry, this part, okay, sorry, let me zoom it. Okay, we do a coronally reposition flap. Sometimes we do a sling suture, any or a vertical mattress suture, anything that will position the flap coronally. Okay. Okay, and then post-operatively, this is how it looks. Okay, so this procedure, I think, is at par or even the difficulty index is well lower than lip repositioning. I think everyone can can perform this with ease. So this is an essential procedure that prior to our aesthetic dental procedures like veneers, is a must. So I think I'm confident that everyone can do this, and I urge everyone to try this in their practices. Okay, so this is the patient a while ago that you think that lip repositioning is indicated, but we only did um, aesthetic crown lengthening. So this is her post-operative picture. We took out the braces. Okay, so this is the post-operative after 2 weeks. Look at her smile, very vibrant compared to the other. Okay. Okay. Wait, sorry. Ayan, sorry, yeah. This is her post-operative picture, and then 1 year prior, no? So she works in a cruise liner. So actually this is a new photo of her 1 year after. This is her new 1 year after photo. So see, no more gingival display. Um, the teeth, has a lot in hiding. So you see that the tooth, that her teeth is bigger now, and she's happy with it. Also, we did the crown lengthening with this. So aesthetic crown lengthening again, post-operatively 6 months after. Okay, so I'm almost done, but yeah, I'll just go through this. Hard tissue issues, no? So in being part of oral plastic surgery, this is also one procedure that uh, I must say that anyone can do, if you have the passion for it. Well, using your piezo surgery machine, it will make it a lot easier than using your burr. In using your piezo machine, it's like using a sharp pencil. Compared to using a burr, it's like using a thick pentel pen, a thick marker. Okay. So thank you, Woodpecker, for this. This is the machine I acquired from Woodpecker, and I'm so happy with it. Okay, I just want to show this quickly. If this is actually not, I don't advise everyone to do this, but if you need help, I'll leave my email later and my Facebook. You can give me a call or contact me there. I can we can talk about it. So here, as you can see, there's a collapse in the ridge of the patient. Actually, she has no denture, and she doesn't like wearing dentures, and she's a little 50-50 about implants, but she doesn't like the um, the collapse or the drooping of her lip. So we actually encourage her to have a bone block uh, augmentation, ridge augmentation, using the bone in her mandible, a block from her mandible. So I just wanted to add this because we made use of the piezo machine, and yeah, actually a lot of the our workshop participants did this for the first time. So we got from her mandible, and screwed it right right there, right? Just screwed it on her maxilla, and I just want to show you after the procedure. So, well, it's really wait, let me show you. So see the difference, no? I mean, that's just augmenting the ridge. What more if she has dentures or dentitions? Hi, this is my daughter. Okay, all right. Okay, another part of the our oral plastic surgery lecture is of course dealing with torice and bony exostosis. So again, comparing the use of your piezo machine in using a burr, it's more precise. It's like drawing with using a sharp pencil rather than using a chalk in drawing. So here you see the tori and the exostosis. So I just want to show you this. These are procedures that you know that entails. That's part of your oral plastic surgery procedures that I'm sure, and I encourage everyone also to do. Okay? So you section first the tori, and then yeah, it's like doing a an odontectomy or a wisdom tooth removal procedure. You section it and cut it. So after 2 weeks, there it is. Okay. So bony exostosis, you see the exostosis here, but the patient actually doesn't want it. So actually, this is a dentist also, one of our colleagues, Dr. Melody. Okay. So as you can see here, it's greatly reduced, so she's happy with it. Okay. Again, yeah, all these procedures that I've discussed, the only secret, I don't recommend any well, you have to know what you're doing first and foremost. And actually, one tip I can give you is before starting, whatever your religion is, you pray first. You pray before starting. Whatever religion that we have, because it's hard. During the procedure, we encounter problems, and that's the only time we pray. I think it's better praying before any procedure. And of course, the secret to learning or to be good at it, it's repetition. Because like what I said, repetition is mother of all skill. And as dentists, it's our obligation to give back to our society. So with that, like what I said, our workshop, the SIDS workshop, the Center for Innovative Continuing Dental Studies, actually what we do there is we get patients, we do them for free. Not only we learn from the patients, but also we get to help them with their aesthetic or their dental problems. So with that, I want to end the lecture um, by this thought, no, we rise by lifting others. So thank you for listening. I hope you've learned a lot, if not some. And yeah, I'll be answering your questions. You can type them down, and I'll be glad to answer them. So thank you very much for listening, and God bless, and stay safe, everyone. So there. I'll be answering your questions now. Okay. Questions. Right. Okay. Okay. So okay, let me read your questions. No. So from Ayat Naji, Doc, is important how many inches to cut tissue? What procedure is this? It's important how many. Okay. I'm not sure what procedure you're asking, but if it's the oh, maybe in the this is the aesthetic crown lengthening. So okay, well you follow a 2 to 3 millimeter inches of cutting the cervical tissue. Don't exceed that because you will violate your biologic width if you exceed 3. Okay, so what you do, you use your probe, insert it inside, insert it, and then you'll normally reach a 2 to 3 millimeter of what do you call this of depth. Okay, so what you do, you cut the tissue from there 2 to 3 millimeters, and then when you do your bone reduction, you reduce it 2 to 3 also. So cut the tissue 2 to 3 millimeters and then reduce bone 2 to 3. Okay, so Ivy Cheng, do you give local anesthesia for depigmentation procedures when using laser? Of course. Well, um, I'm not really not familiar with lasers. In if its effect with I think that was discussed by the previous lecturer, lasers. But when we did ours, when we did my first, actually my first and last laser procedure, it was with Dr. Jerry Dison. Um, we gave anesthesia, no? But I'm really not so sure about it. Please ask a laser specialist with this, no, regarding this. But personally, um, I like the healing of the tissue when there's, well, I'm not against lasers, don't get me wrong, but I like the healing of the tissue when there's blood. Remember, I always say this to our students: when there's bleeding, there's healing, because that's the mechanism of the body. It sends blood, it rushes blood to the area to heal it. Now, if you take that away, that mechanism away, I mean, there is healing that's going to be done under, but of course, it's not as it's like festoon when you're doing your festooning during back in the day during college, where you carve the wax and then you blow a flame over it. It gives you a smooth um, result. So for me, blood is like that. It gives a really good healing on that area. Okay. But I hope I answered your question, Ivy. Okay, from Farah Nadira, is depigmentation permanent or it may recur? Well, in our procedures that we've done in our workshops and in our patients, as long as that's why having, for example, a piece of gauze, um, you don't soak it. It's just wet with anesthesia with epinephrine. Every time you fillet your gingiva, every your tissue, you have to check it. You have to see if there's pigment still left. No, you have to address every other pigment. Dab it because blood's gonna ooze. No, after dabbing, blood's gonna ooze. So now recurrence happens when you leave some. That's where it recurs, where it happens. But in our cases that the 1 year, 2 years, it hasn't recurred yet. So there. From Berazuga Latifa. I hope I pronounced it correct. Hi, is there recurrence of pigmentation? Well, yeah. In our experience, as long as you address all the pigments, there's no dark stains left. It's not gonna come back. Um, you might be asking again, what if it reaches the epithelium, the bone, okay, and you're filleting almost the bone area, okay. Don't worry, epithelium is still there. You did not reflect it. No, you did not do a full thickness, so don't worry. The bone is still protected with the epithelium. Okay? Do we cover the gingiva after this or just leave it? Same doctor who's asking. So do we cover the gingiva after this? Okay. Literature says to put a periodontal dressing, Copac. No? Personally, we don't place Copac because it's easier cleaned, easier irrigated, easier reached by your warm water with salt. By the way, that's the cheapest and actually very effective mouth rinse. You know? The warm water, the temperature promotes blood flow, and then the salinity cleans the area. So yeah, with that, it's easily cleaned. But with your period dressing, it's there's food debris, that can hinder healing. Okay. Oh, sorry. This question came from Ahmed Mustafa. Hello, Ahmed. So next question from Noran Mohammed. How can we conserve tissue till secondary intention? Okay. You're asking this. Maybe this is you're asking how can we conserve tissue? Okay, it will heal back. Remember, we did. You're referring to gingival depigmentation. So, okay, our gingiva, whether you like it, the good thing about the mouth, the oral cavity, whether you injure it, you cut it, you're injured, trauma, anything, you accidentally bite it, because of its vascularity, because it's very vascular, whether you like it or not, it will heal. Because that's the good thing about an area being vascular. It will heal no matter what. So your question is how can we conserve the tissue? Okay. When we do depigmentation, we fillet that certain tissue, that certain stratum where the pigment is located. Okay. Like what I said, it's like doing gingivectomy without, or doing crown lengthening without reducing the bone. It will come back. So you're asking if we were concerned, we cannot. It will come back. The thickness of what we cut out, of we filleted out, it will come back. So don't worry about that. Okay, from Dr. Ramya Gaurav Tredia. Doesn't shrinkage happen after surgery? Yes, it does. In doing flap surgery, when you're doing your flap surgery, shrinkage. That's why I was stressing out a while ago to do a papilla conservation flap. So in a papilla conservation flap, you conserve the papilla. You leave it there. So when shrinkage happens, you won't have any black triangles, most especially in the aesthetic zone. So where does shrinkage happen also? Yeah, that's why also in suturing, it's very important that you remember. Again, I'll stress out, when there's bleeding, there's healing. That's why when you coaptate tissue, it has to, somewhat de-epithelialize it so that it's like a Velcro. It has to be blood and blood that's gonna stick. If you do epithelium, keratinized epithelium to keratinized epithelium, you will, that's why they what you call this non-coaptation happens, because yeah, and you probably view it as shrinkage. Okay, so okay, wait, next question. Sorry. Okay, from Mustafa Al Adharhami. So if you don't do the periopack, what do you do instead? If you don't do the periopack, what do you do instead? We just leave it like that so that the patient can can gargle with warm water with salt, then irrigate it with chlorhexidine. Post-operatively, we leave it like that. Remember, the body. Maybe you're thinking without a periopack, it's gonna heal poorly, or it's not gonna heal. Complications can happen. Remember, the mouth to start with is the dirtiest part of the body, bacteria-wise. So it's dirtier than our feet. When we don't wear slippers or shoes. So it's adapted to that situation. So given that your oral hygiene is okay, you don't have any, your salivary flow is good, serostomia is not present, it's perfectly okay to leave it like that, to let it heal secondary intention. So try it. You'll see the healing. It's faster without a periodontal pack because you're able to clean it. So I hope I answered that, Mustafa. Okay, next. Okay. Okay. Next. Okay, from Ayat Naji, what age is good for surgery? Girl or boy is different. What age is good for surgery? Okay, of course, for lip, we're dealing with adults here. You cannot do lip repositioning in pediatric patients because they're still developing. Their development will actually alter your final result of your surgery. So we're dealing with adults here. Also with crown lengthening, you can't do this in a toddler. So no, a boy or girl is different for surgery. Well, that's the same. I mentioned the gender a while ago that girls are more likely to have more the gingival show is more likely to happen in female, but you can do girl or boy. It doesn't matter. So from one of the most respected and celebrity dentist, Dr. Gina Imperial Abad. Okay, she's a very celebrity like dentist in the Philippines. So how deep would be the incision be? Would it only be superficial? Okay, what procedure is this? Maybe you're talking about Dr. Gina lip repositioning. Okay, of course in the attached gingiva area, you want to the depth of the incision would be until the bone. When you reach the epithelium area, the one in on top, no, the unattached gingiva, your incision would be only epithelium depth. No, you don't reach the muscle area, only until the epithelium. So how would you know the muscle area is around maybe 5 millimeters deep? It's the length of the whole blade. You only the depth is only until the epithelium, which is around 2 or 3, the most 3 millimeters depth. I hope I answered that. Celebrity dentist, Dr. Gina. Okay, Mr. Pakar, what suture is your most favorite one for intraoral stitching? Okay, well, remember guys, in your normal suturing of incisions, we use our non-absorbable sutures for only one reason. No? Well, that reason is for the patient to come back for us to see the results of what we did. Okay, so that's the reason, because we could use absorbable all the time. I mean, not worrying about, okay, don't come back, you're good to go. We use absorbable, it will melt on its own. But we use non-absorbable sutures so that the patients can come back and for you to remove those sutures to check, did I do a good job? Was there any complications? So that's the reason. So if you ask me, my favorite is um well, I like using I mean silk, the very very basic, silk. I started from that. I mean, I'm so used to using that. So yeah, invest in good sutures, sutures that won't lock when blood is dried. No? So you invest in good quality sutures, so you make your job fast. Okay. From Jonathan Jong from Malaysia. Any idea if general dentist wants to practice such surgery? Any course or certificate is needed? Oh, okay. Well, that's why the title of the lecture was oral plastic surgery for the general dentist. So the procedures I mentioned a while ago, no, except for of course I stressed it out a while ago, the connective tissue grafts, no, it's a very technique sensitive, and I don't encourage the general dentist to do this because periodontist, it's a periodontist work. I mentioned that a while ago. Also the what do you call this? Yeah, I think that's the only one I mentioned that I don't encourage everyone. But all of this here in the Philippines, you don't need a special certificate to do this. No? It's also like what I said. It's before you do something, you have to, of course, study it, know it, and I was encouraging general dentists to do this because the difficulty level of the procedure is not that high. Like for example, depigmentation. It's like peeling fruit. It's not technique sensitive. So yeah, and also lip repositioning. It's just it's like repositioning. It's like pulling down a curtain. To if layman's term. So if you're asking if you need general dentist wants to practice such if you need certificates, well, here in the Philippines you don't. Once you're like a licensed dentist, but of course, like what I said, technique sensitive procedures, we refer to the specialists. So from Norhan Mohammed, in class 1 gum recession, did you just remove composite with piezo surgical machine? Therefore, migration of gingival done, or did another step? Okay, why didn't I use a burr? Well, number one, I was showcasing woodpeckers piezo, that it's a very useful tool not only for bone surgery but also for dental procedures. No, I could have used a burr, no, but just because of the because I was showcasing woodpecker, and woodpecker sponsored this webinar. That's why I used that. So with your gum recession with piezo surgical machine. Okay, the steps that we did is after removing composite, so the dentine was left. We we used EDTA, to we placed EDTA to decalcify the surface of the dentine, and then used a very very sharp Gracie curette to process this, to what you call this, to scrape it, to for us to get new found dentine underneath. No? So after this, no, sometimes with the infected areas, they use antibiotics, and then they use antibiotics to scrape it. But we didn't do that. After that, we irrigated it copiously, and then placed the connective tissue, and then made a coronally repositioned flap. So very basic, no? The very basic of your connective tissue graft, it has to be stable. It has to have blood supply. Okay, so if you're using, why didn't we just use a burr? I could have used a burr, but just to showcase what the machine can do, we use the piezo. Okay. Okay. Wait. Last couple of questions from Jigger Fuentera. Hi, Dr. Carlo. For CT graft, what will happen to the palatal area? That's a good question that you got the tissue from. Will the periosteum be covered with a new tissue? If so, how long is the healing process? Lastly, are we supposed to put Copac or any covering for the patient comfort after the anesthesia subsides? Okay, very good question, because I failed to include it in the presentation. So thank you, Jigger, for asking this. Okay, what will happen? Okay, remember, it's the procedure. It's like imagine a sandwich, no, a ham sandwich. So bread, ham, bread. So in connective tissue graft, we're just getting the ham, and then the bread stays there. Okay, so you have to practice this. No, the angle of the scalp, the blade is crucial in harvesting this. Okay, so will it heal? Yes, because there's a keratinized epithelium that you're gonna leave, and you're gonna suture there. Okay, it's gonna heal. Well, the healing, well, it's more. It will take a little bit longer than your normal mucosa that's found buccally, because you got the connective tissue area, no? So that's a little longer to heal, around 2.5 weeks. Okay. So what will be the cover, you're asking, no? Sometimes we place a stent, no? You use your vacuum former, no? You just get a mold of his upper dentition, and then use a vacuum former, an acrylic stent, just to push the area. Well, sometimes we use Copac, just a couple of days, so that for it to clot. We just want it to clot. That's the most important part. That's why coughing, sneezing, or spitting, those are negative pressures, and using a straw are a no-no because it can dislodge that clot that we want. So thank you, Jigger. I hope I answered your question. No? So this is more, no, this is uncomfortable talaga. The one in the palate. It's much more uncomfortable than the one in the buccal area. So okay. So from Jasmine Chong, doctor, for the removal of mandibular tori, no need to raise a flap during trimming the bone. No, the flap was raised actually. Okay, you just have to be careful on the lingual area. The biotype of the gingiva is thin. You can easily tear this. So that's why the incision you make is make it a little. Kumbaga, it's like doing your extension for prevention. Your flap, you have to extend your incision a little farther so that when you reflect it, you have uh, extra gingiva to spare. Okay. When you remove the tori, of course, that's extra tissue. It's better that you have extra than you have none at all. So you bring it back. There's gonna be a lot of extra tissue remaining. So you just cut that out after you suture. I mean, you what do you call this? When you suture it back, you suture it back into place tightly, and then the excess tissue that is going to be left, you just cut it with your scissors or with this, your iris or your number 15 blade. So what else? Okay, I think that's the last of the questions. Okay, so thank you so much, everyone. I hope you've learned, if not a lot, some, and you may incorporate it. I encourage you to use all of this that we've discussed in your practices because it's an additional service that you can add, you know, that you can profit from. So stay safe, everyone. Stay healthy also. So God bless. Thank you for listening. Thank you. Okay.